But hopefully it'll be a really useful, interesting session to help you just cover this topic, which for some of you may be a real sticky problem for you. So I'm going to hand over to Matt, and he's going to lead us through the next part of the session.
Thanks, Nick. Morning, everybody. My name is Matt Noonan, and I work for the Exeter Care and Improvement Support Team. As Nick's alluded to, we've sort of designed today's session to try and be as interactive as possible, and I guess use the collective brain to sort of discuss and hopefully come up with some potential improvement ideas to try and help this problem. I think when we sort of started this program and canvassed ideas from various people in the cancer world, this topic around how MDTs across providers work together came up in almost every discussion, and came up as quite a challenging area for organisations that cause a lot of time and energy, especially when it comes to things like performance, but also in just terms of the patient pathway. So we wanted to use today to understand, I guess, some of the challenges you guys are facing and the things that you maybe have come across in your career. It may be that some of you now, some of you work in MDTs where actually you're not part of a inter-provider world, but your ideas and your input will be great received. And obviously, if you are part of an MDT, your views and the things that personally challenge you will be really welcome to hear. So the way that we're going to run today, we're going to do a bit of interactive stuff using Menti, which I'll just put up on the screen. So if people want to, actually, if I could ask one of my colleagues to put the link to www.menti.com in the chat, then people just click on that. But if you do have a phone, you can use a QR code. Just go to the website and put in this code. I'm just going to do a couple of quick things, just to one, just to check it works, and then two, to sort of get your views on the challenges. So we're going to start there, and then we're going to break out into groups to sort of discuss hopefully some themes that come up through the interactive session that we're going to do now, and then get back together at the end to sort of talk through what the discussion has been. We're going to try and make sure there's someone from the team in each session to help sort of facilitate and record stuff, so you guys can concentrate on the discussion as opposed to having to worry about scribing anything. So if you're able to open menti.com and go to put this code in, and you should hopefully be able to see a screen that looks a little bit like what's on the top. So yeah, people are already on the go. Great. So yeah, if we just get some initially we just wanted some thoughts around some of the challenges, or some of the, how does your relationship work currently, if it's something that is an area that you're involved in. And the first three on there, that's good. So we've got two sort of challenge ones, one which actually seems to be great, seems to be working well, which is really good. So hopefully the views of that person today will be really valuable, because it'd be nice to hear about the things that that are working well, as well as just the challenges. So I'll just give people a minute or two to get online and add anything that they want to do.
So we've got 4 responses so far of the little character in the corner there. You can pick up 4. So we've got 28 people on the call. So yeah, so we can see that ticking up now nicely. Put the code in the chat if anybody needs the code to go to menti.com.
Thank you for putting your thoughts in, everyone. So far, I'm really only seeing one positive, which is the speedily term, which is a very good word, by the way, and a lot that seem to go along the theme of things being unclear, variable, strained. Lack of feedback. I don't know whether that's from the SMDT side or whether that's from the local MDT side. So maybe we can expand on that when we go move into breakout groups in a bit.
So and then so that this slide was just to get a bit of a flavour of views. But if we're able to move on to the next one, hopefully Nick, you can move on to the next bit of the Mentimeter. That should open up so for ability for people to sort of expand a bit onto. So here we're just really keen to understand, you know, what people see as the sort of biggest challenges when it comes to the interprovider MDT working. So we can hopefully this will give us some themes for us to discuss as a group going forward. So be really keen to hear from everybody to around what they see as the challenges. And if you are an MDT that doesn't have this, if you've got insight from discussions with colleagues, it'd be really good to hear.
Yeah, a couple of thoughts coming through really quickly. Delays with updates from Tertiary Trust and too many patients, not enough time, which I feel could be a mantra for a lot of parts of MDTs. MDTs occurring at the same time, so that's obviously a bit of a scheduling issue. Lack of single patient record. I'm guessing that's between the local MDT and the specialist MDT. So yeah, please do keep adding your challenges, everyone. The more the merrier, whatever springs to mind. Particularly those people who put their thoughts up about the relationship being quite strained and stressful. It'd be interesting actually what causes those feelings and what the challenges are behind it. Somebody else has mentioned when it's not clear when the patient should be referred. Not working out patients prior to referral. Management advice and additional verifications vary. Lack of agreement on workup. So again, about workup. Incorrect details or incomplete details. Lack of clinical information. So there's a link there. Patients being referred with test outstanding. So again, that's related to the workup. Poor referrals with no information. So that links back to the lack of clinical information. Oh, screen's got a bit funny. Outcomes unclear. I'm guessing that's from the specialist MDT slide. And the communication back with the local MDT. Repeat MDT discussions as results not available timely. So I'm guessing that's from the results from the specialist MDT back to the local MDT, and a comment has just popped there, very similar, lack of updates back to local MDT. So again, it's that kind of communication link between the two. Lack of PACS integration, again with systems, difficulties with transfer of images. Oh, we've got quite a few already, so that was 15 responses so far. Don't know if anyone in our last kind of minute wants to add any more. Oh, no representation from the referring trust. Okay, so patients getting referred to the specialist MDT, but nobody being there to present them. Unclear what tests are required prior to referral and or change in requirements. I suppose that's from the other side. So the specialist MDT may see a patient who's not been worked up. The local MDT may be unclear of what the workup is actually required. Not been invited to join at the tertiary trust. So again, that's the kind of other side to no representation from the referring trust. It might be that the referring trust isn't actually invited to participate. It's really good that we've got some challenges from both sides, actually. So we can see the issues from both perspectives. That's really good. Contradicting information on the referral form. Yeah, so that links again with clinical information available. Old referrals being updated with slightly new information which causes contradiction. Yeah, again, linking back to information available on referrals, which also appears to be a theme.
Okay, if that is everything, or just yeah, we stay there next. So, just give me 2 seconds. We're going to try and group these. So I think looking through the comments there and the themes that Robin's helpfully sort of summarised as we've gone, I think there is something then about sort of the referral process in terms of the process, the information that's required, some challenges around conflicting information. It looks like there's then stuff around just the workup about patients, so what is expected to have been done clinically by the time they're referred, which I'm going to put slightly different. They're obviously quite linked, they're quite closely linked, but probably some slight differences there. I think then there's a sort of group of stuff around representation. There's a group, we heard some stuff around sort of timings of MDT in terms of amount of time when they occur, and people either representation being an issue in terms of either being involved or not being able to attend, which might link to when the MDTs are actually running. So I'm just going to group that together. I'm just going to bring the slides back up, as I've now updated them following that. So bear with me 1 second. Yeah, I think so. In terms of the things, so I think the time is into the amount of time, representative referring trust not being involved, and then a sort of feedback process from MDT appears to be the main thing. So if Robin, if there's anything else that you would add to that from what we just talked through,
No, I think that's I think that's a really good summary, Matt. Because clarity on workup again works from both sides. So, that's what workup the specialist MDT is expecting and what workup the local MDT knows to do.
Yeah, that's exactly right. So what we're going to try and do now, we're going to break us into 4 groups. So each room is going to tackle one of these sort of topic areas. So I think with the breakout rooms, it will be clear which room you're in. But I think maybe in terms of just being super clear, I think Dua can assign some of us to specific rooms. So should we say when I take room 1, so I'll work with everybody on the referral process and what information is required. Robin, if you wanted to do clarity on the workup room 2, if you could put Alison into the one around timings of MDT representation, and if you put Nick into the last one about feedback processes, then we will then at least whoever gets in the room with us will know what they're working on. So the plan is we're going to have 20 minutes now where we're going to just talk through these things, look at the sort of causes of the issues, and try and create a list of possible solutions. And I think just the key here is not just the solution. So as an example, you might say we need a policy about something, but then what are the actions needed to sort of get to that process where you've got an agreed policy? Because I think in some cases, the answer might be obvious, but actually getting there is the challenge, and that's what we want to try and talk through today. Like, what are the steps that could be taken to get people to the solution? If some of the challenge, I think there's a sort of technique that we've used in previous sessions, and I've used when I've been to sort of sessions like this. That if we sort of get stuck, or there's stuff that some of the things might be very big ticket, difficult things to control, but there might be smaller things that also can be done to sort of start the process. And so, sort of reverse brainstorming technique, sometimes it's worth thinking through, like, if you wanted to make this as bad as possible, what would you do? Like, if you could make this process the worst it possibly could be, because then that sometimes gives you like examples of things, smaller things that you can do to make it better. And so I've put an example there in terms of like, if we never answered an email, that would make it really bad. So actually the flip side of that is actually, okay, maybe we should need to have some kind of agreed time frame for responses, or joint, centralized inboxes, and all that kind of stuff. So just think through that. Some of these things might be massive, some of these things might be really small things that can just start an improvement process, not necessarily having to solve the whole thing in one go, but just taking small steps to bring people close together. So once we've done that, Dua will call us back in, and then we'll sort of have 10-ish minutes each to sort of summarize what we've heard, what some of the ideas have been. We will capture everything from today's section, and then we'll come back and sort of wrap up and look at, okay, what are there things that people think that from today they can take away and hopefully use to start a process to improve things. So the pressure now moves to Dua to try and move us all into rooms, which hopefully will be really straightforward. Good. Thank you very much. I hope everybody had some good discussion. So what we'll do now is I'll get if anybody outside of our team want to feedback from the teams, but I was in the room once, so I'll feedback a bit about what we just discussed, some of the ideas that came out of it, and I'll hand over to my colleagues. But please, if you feel free to put your hand up and add to anything as we go through. We were discussing the referral process and what information is needed and what came up, and fortuitously we had a trust in the room that had tried to do some work on this. So some of the colleagues from Sheffield were talking through the process they've taken back recently to try and enhance it. So that the first one, sort of unsurprisingly, might be having a sort of set standard pro forma for referrals, clear information. They discussed that they don't. This is not a static document. They are constantly reviewing it and updating it to try and make it as effective as possible, being as really clear what is needed, and trying to sort of make that as effective as possible. They seem they have quite a good sort of alliance process where they have regional meetings quite regularly, so they're able to use that forum to discuss it and to sort of communicate it across the services. they also talked about a historic situation they had that they're now trying to reenact, which is having a presence in district hospitals, so being able to attend local MDTs, because that helps improve the quality of the referral and also the clarity of when that referral should be made. We also heard about, I personally have had experience when I used to be a cancer manager on having consultants with joint contracts across DGHs, which was a very effective way of sort of them being able to do clinics and also help refer patients in. So there are some areas like that Sheffield are looking now to get people back out into district hospitals. Obviously, use of technology can help us sort of attend MDTs, but there are challenges around timing. So I'll look forward to hear about some of the conversations that have happened in one of the other groups. We also had some comments about referral performance in terms of really being clear about what is the critical points of information that will help move the patient forward. So really streamlining it back to the things that you absolutely need to know. Having that clarity so that everybody knows that that information is needed, because often a lot of referrals come back half completed. So again, having that ability with the Cancer Alliance to sort of do that. And we talked about actually one of the key things, one of the things that causes probably the most problems in terms of when referral information is correct is a lack of sort of fitness and performance status, or it being incorrectly calculated. And so we talked a bit about actually using networks to help sort of facilitate education sessions. Often in a lot of DGHs, it falls on a CNS to complete the form. They may not have seen the patient. So actually trying to do some work with both the clinical teams and the CNS teams to sort of be really clear on how we add defining performance status, and that is recorded, because that is a thing that causes a lot of sort of back and forth and potentially conversations around patients that wouldn't be necessary if that was accurate. And then other things that were mentioned, that there are potential sort of electronic referral systems that could help. That sort of mandate certain information and referrals can't be made. So there is a cost to those, but the time, there is a lot of sort of wasted time in terms of conversations that happen and they're incomplete because not all of the referral information there. So there's having a system that sort of screens out or inhibits referrals could potentially improve it. And then I think one of the things, one of the barriers we picked up, we sort of ran out of time to talk about, is a little bit around just funding and the capacity of CNSs and in the teams, and that they're a vital cog in the wheel, and they're often, especially they're often under-resourced and a challenge around that. So I think again the use of the Cancer Alliance is to sort of help facilitate and leverage some of that is a possible. But yeah, I think in summary, I think the major stuff was, I think, really streamlined performer. I think if anything that could be done to have presence at MDTs, both as a SMT going out and an LMT coming in, it would really help. And some sort of education sessions to be really clear on why these things are being asked for and how to clearly define them were the sort of the headline points from our group. So I will hand over. I can't remember who I put into room 2. Was it you, Robin?
It was me.
Okay, was it you?
Yes, I think that me and Robin fought over it for a little while, and then I landed there. So the group nominated me to do the feedback, but please shout out if I forget stuff. So it's interesting that actually our themes really followed on through exactly what you just have been talking about, Matt. So the clarity on what's required. So a lot of the time patients are being referred over and they're unfit, and so they're having to have those further workups, the echoes, etc. But from the local side, actually some of the requirements pre-surgery are different. So what you'd need at one site before is different. So we hit upon, and a couple of the sites have really started to work on this, is the electronic referral form, which really sets out if your patient's got this status, they need this workup prior to do it, and actually these are mandatory. So until you can tick to say that that's happened, that referral can't go. And I think two of the trusts are already doing that, and it's starting to work for them. But that was our main issue, was the fact that actually it's not generally that normal pathway. You kind of know what tests need to be done. It's that additional stuff. So when patients aren't well or unfit and they're having surgery, what's that additional stuff? So having a really clear pro forma. So even though you might not do that at your local trust, if that's what the specialist trust need, then you know about it, it's there, you're aware, it's all on the pro forma, so it's really clear. And I think one of the other, and again, following exactly what we've just said, one of the MDTs that we had there was a lung MDT, and actually the thoracic surgeon from the SMT came down to there at once. So it was really clear right there and then what was required, and is this patient ready to go? So it was so for us, electronic referral pro forma, and a really good clear pro forma that's got that kind of level of detail that you need. And it might be like there's lots of not applicable, but actually having it there so that you know what they're going to be asking and what they're expecting. I think so. Yeah, I'll leave it there because it was quite similar to yours, but yeah.
Great. Thank you, Alison. Does that mean, Robin, you're room 3?
I am room 3, yes. And I will summarise. So yeah, we were talking about representation and also the timings of the MDT, and we did find that they were quite often linked. So firstly, we defined that actually we felt it was essential that somebody from the local MDT attends the specialist MDT in order to present their patient. And one of my group, I wrote the quote down: it ensures a well-prepped patient for discussion, and MDT discussion always benefits from somebody knowing the patient, being in the room. We also discussed that actually at the specialist MDT, it needs representation from multiple disciplines. So, it's obviously really difficult if an oncologist is attending, but the patient is actually surgical. So actually you might require representation from multiple disciplines at that specialist MDT in order to ensure all the patients are presented and the discussion is reasonable. We thought that a barrier to that could actually be job plans at the local MDT side, and it obviously needs consideration from the local MDT organisation. Job plans need to be rearranged and time added in order to participate, and obviously that can be quite difficult, but it's really important. And I would suggest again, Cancer Alliances could help lever that conversation in a local trust. From the SMDT side, though, the specialist MDT could have allotted times on the agenda for the local MDT representatives to join. So, for example, they could have a slot 10 till 10:15 where they discuss patients from a particular organisation. That organisation joins the specialist MDT electronically to do that. However, we did say that actually the specialist MDT needs to be able to be flexible. So if somebody from a local MDT is delayed, if a previous discussion takes a bit longer than it should have done, and obviously the timings get a bit messed up, you need to have that flexibility in the MDT to be able to chop and change things around to facilitate that discussion. We also discussed actually allotted times where the local MDT and the specialist MDT become one. So that's somebody put one of the challenges was that their MDTs were at the same time. So if you're having that where the MDT is actually at the same time, consider a time on both your agendas where you join via Teams or other video conferencing to actually merge your meetings into one. So that ensures that everyone is there. But again, you have a set time, so you're not disrupting other patient discussions that need to happen, and everyone's available. We also discussed actually when you're planning a specialist MDT, you need to have consideration of timings when you're planning, so including consideration of cut-off times, because if you've got a local MDT that happens perhaps at the same time or after your specialist MDT, obviously that then builds in a delay to the patient pathway if your cut-off time then doesn't facilitate that. So it does require good communication between the specialist MDT and all the sites that are referring into it, and respect for everyone's time and consideration of all those elements. I think that just about sums it up.
Thanks, Robin. I really like the idea around when you've got MDTs running at the same time, just actually trying to find a time together where you can come together. It seems a really sensible and straightforward way to try and resolve some of these problems. So thank you for that, and thank you for the people in the room. It sounded like a really effective discussion. So I think, Nick, you're last up. So now Nick doesn't work in cancer ever, so people in this room definitely need to give him some support here. We need it, although he's pretty good at doing these summaries. So I'll have over to you, Nick.
I was just listening to the conversation and just taking notes. I'm just the admin, to be fair. I think so. Thanks to Room for some really good discussions, and we went to probably root cause analysis of some of the challenges and building on. I think pretty much cross-cuts all the discussions so far. So we're looking at feedback between the MDTs and some of the challenges that they experience. And I think when we look at that, we can start to think about what's the root cause of that feedback. And quite a few of the comments was around the volume of patients that are trying to be seen through the MDT will naturally constrain the amount of feedback that is available, because we try and keep it brief, but that brevity sometimes leads to further questions being needed, and therefore we extend the process. I mean, we talked about links into the attendance. Where we don't have attendance, we rely on a process to enable information to be transferred. So we discuss the patients in the MDT, we then capture that and then just share that on a document, which requires then somebody to read that document and then feedback if they got any questions on that document, and it becomes almost a duplicating process. So some of the things we're talking about is the attendance and how we can look at appropriate attendance. As I say, we don't want huge numbers, but again, links into the sequencing conversation. If your local MDT is on a Wednesday and the specialist MDT is on a Thursday, we're never going to get the information back. So one of the colleagues mentioned about that always builds in a week delay at least, because we sort of moving around that cycle. Job planning, we touched on already. That was brought up as one of the root cause. If we're planning to fail, we will fail because we've built in failure into it, because we're trying to job plan people at the same time. So how do we set the scene to enable us to get the best outcome? So job planning may end up being, do we look at the availability of people? I really like the idea of, within the specialist MDT, how do we get attendance at the right point so people don't feel like they're there listening through other people's conversations. For me, there was an element of the process itself creates more work. So it's one of those self-fulfilling prophecies that we're creating more work because of the volume of patients. And I think it links back to the session last time around streamlining of MDT. So this very much, the attendance, the feedback links to the streamline. Are we speaking about the right patients in the MDT? One of our colleagues in the room suggested that, whereas it feels like we are creating more work, actually separating out the MDTs into different conversations in a different MDT. So as we talked about last session, how do we streamline to get the right patients on? That allows us to have appropriate feedback, and it almost becomes an ability for us to have immediate feedback if we've got the right people in the room as well, rather than relying on a transactional process of sharing that information. So it was all about root cause analysis in the room, really understanding what are the barriers to feedback, what are the enablers. And I think what we identified was, how are we discussing the right patients in the room? Have we got the right attendance in the room? And can we sequence this in the right way that enables a smooth flow of information between people, so we can have both giving feedback and receiving feedback at the same time? I hope I haven't missed anything out.
Thank you, Nick. That's And thank you, Ruby, for your candor and your contributions. I think it's interesting, isn't it, when you hear the feedback in that flow, that actually how much everything is actually linked together, and then links back to the streamlining conversation we had last time, and how all this stuff sort of one thing enables another, enables another, enables another. I think there's some big things there. There's some the challenges around dealing with job plans and putting in electronic systems and stuff. They are sizable things and sizable challenges, but there are some things that for me were a bit more on the low hanging fruit stuff. And if I think that to my group, having a process whereby the pro forma is just regularly reviewed and talked about in meetings that already exist is something that's straightforward. The stuff from you, Robin, around the joint timings. I think there's some tangibility there, and that links into what you just described, Nick, in terms of that feedback. That feedback's much easier if people are in the same room as opposed to waiting for 3 lines on a spreadsheet or something. So, Robin, you've got your hand up, so I'll let you come in. But some interesting stuff there.
Thanks, Matt. Just a thought that occurred to me actually when you were talking about referral forms being regularly reviewed, and actually in terms of communication and feedback, I think it would really help actually if there was a forum outside of MDT, a regular forum for local MDTs and specialist MDTs to come together to discuss these things. So actually, whether that's an away day once a year, or whether that's a meeting once a quarter or once every 6 months, where actually everyone gets together away from the MDT, so you're not burdened by the volume of patients and trying to have clinical discussions at the same time, but an opportunity actually for everyone to come together to discuss any issues that come up openly, to review pro formas, to review patient fitness requirements. Actually having that space, I think, could really help some people if that can be facilitated.
Yeah, I would agree. Fab. So, well, on the plus side, we're also going to probably give you some time back. So I think the last bit that we wanted to sort of come back through there, unless I'm just going to pause, see if anybody has any further comments or anything that they wanted to add to any of that discussion. But
Matt, just to say, I'm just going to drop a comment into the chat. Just thinking about the pro formas and work that's already been done. If you're happy to share any examples of pro formas that you've got within your local trust, if you can drop me an email, I'll put it in the chat, and then we can put it onto the resource page of the futures, so that everyone can see them. So I'll just drop that. Thank you. So
that's a really good idea, Alison. Thank you. And we are also going to write up everything that's come out today and put it onto the resource page so people have it to reference back to. Dawn.
Thanks very much. I just really wanted to add that we've been quite fortunate in our Cancer Alliance to have, in 2 successive years, have MDT workshop days. And actually that's got us to the point that we are now, and there's been some really, really fruitful discussions in there, and I think that has helped with the onboarding of our cancer units into central MDT as well. People have felt empowered to say, actually, I don't agree with this, or I don't agree with that, or why are you saying this? They've really allowed that friendly challenging with kindness about how we do things, and I think we're seeing that now, the patients that are coming through. So we've got that buy-in for the MDT now, units representing well-prepped patients coming through, but also local teams feeling more comfortable and confident to have conversations with patients before they come to the specialist clinic. So I think we've sort of gone full circle, and we've got another day planned this year. And when we did word clouds and things like all them nice graphic-y things, the patients that the main word that came out both times we've done it is patience and process. That patients were the key part of the MDT, they were the most important part of the MDT, but we had to make the processes work to benefit the patients, and that has been 2 years in succession, and they've still come out as our top themes. So although we're making improvements, we want to be even better.
Yeah,
thanks.
Thank you, Dawn. That's very powerful. And I think for me there, that like, it's amazing what a day a year can do. Like, that isn't, like, we're not saying you need to meet every month, or, you know, it's a small commitment. It's still a commitment. It's still time away from, you know, the home base and stuff. That's not insignificant, but to hear the impact that something as relatively small as that has made is really powerful. So thank you for that. The last bit, I think, hopefully we're going to go back to Mentimeter. So unfortunately, if you clocked off, you have to go back on. I'll put the code back into the chat. I just want to, if it'd be good if people, if there is something that's chimed with you today, hopefully you can still see the stuff in the chat. It's a bit further up now. Nick put a link in. If there's anything that's chimed with you today that you think, okay, that's something we can take away, I'd be really keen to hear it. Like, you know, the purposes of obviously this whole program is about improvement. So if there is stuff that you think, okay, that's something we can add to the improvements we're trying to make, then I'd be really keen to hear what you think you can take away from today. So we'll do that, and then we'll wrap up today's session. Hopefully we'll get some responses.
So somebody's already commented, communication among team members. The idea of an online performer with mandatory fields. Yeah, obviously that came across in quite a few group discussions. Look to run an MDT away day. Shared challenges are very evident, and we can use this to get more engagement. Absolutely. Again, online performer. And also, if anyone knows actually systems that facilitate the creation of online performers, please do put them in the chat as well, that people can refer to. I know at a trust I used to work at, we used ICE to do our MDT performers because our reasoning was everyone in the hospital had access to ICE. People usually had it open on their desktop, so they were easily able to log in and do the MDT referral that way. Somebody else has put MDT away day. So thank you particularly to Dawn for sharing her experience of that. The idea in MDT, teamsing in with other MDTs, continue with the away day, is that making a huge difference? Yeah, that's obviously really resonating with people. I think I would add as well, not something to take away and implement, but a theme really from today's discussion is actually how important all those elements are. So how important local discussions are to specialist MDTs, how important representation is from both sides. Actually, it's not just dependent on one MDT, one discussion. It's dependent on everyone working together. I think that came through quite strongly.
Thank you, Robin. I absolutely echo what you just said. I think you're absolutely right. So thank you for those that have commented. Hopefully, if there are others who have time to reflect on discussions today, and as I say, we will write up and sort of put on the resources page a list of all the stuff. So for those of you that were maybe had more of an interest in rooms that you weren't in, you'll be able to see the sort of discussion that was held. So thank you for your time. Nick, I know you normally do the closing bit, so I'll hand over for your wise words, and then we'll let people get back to their day job.
Thank you for. I'm not sure going to be wise words, but I'll close us up and wrap us up. Give us 20 minutes back. Thank you for all your contributions today. Felt like a bit of a different session, but really important to sort of dig into some of this some of the more wicked, knotty problems. I think what we picked up on in our breakout room, and I'm sure it's there with the others, is that if this was easy, it would have been solved by now. So it's just about, sometimes you have to sort of dig into it a bit harder than we normally would do, and it's about what we've previously about, just trying stuff out. You probably won't get the solution straight away. But it's tweaking and trying, and just if you've got an idea, give it a go and see how that works. With that proviso, or caveat that we are all learning and we're all trying to discover as we go. I think particularly for me that some of all these interconnecting parts, there's not just one silver bullet solution. It's all about a lot of the multiple things. There are no silver bullets anymore. It's often about just lots and lots of little things that all build up to an overarching aggregation of marginal gains, I think was the phrase that was used previously. So huge thanks for today. Join us again on the 1st of April, same time. And I think that one, I'm just going to check my notes. We are looking at that one is how we prepare for an MDT. So again, links really well with the conversations today and some of that sequencing and job planning that we talked about, and getting the right people there and the right conversation. So thanks a lot again for your time today. Hope you have a splendid rest of the Friday and a good weekend. Looks like the sun's shining across the country. So look forward to seeing you all on the 1st of April. And that's not a joke, by the way.
Oh, thank you.
Thank
Bye-bye.
you.
Thank you. Bye.
Thanks. Bye.
Bye.